Hi, today I am presenting an overview of some of the areas of application for behavior modifications. This presentation is based on Chapter 2 of Martin and Pear's Behavior Modification, what it is and how to do it. Behavior modification has been effective in various types of settings and in working with individuals that vary in age, intellectual, and skill levels. Behavior modification has branched out into different types of fields such as sports, business, and industry. These are places one would not typically think of applying behavior modifications. Behavior modifications have been successful in the area of parenting and child management. During a child's formative years, the parents are completely responsible for the behaviors learned by their child. As time progresses, other individuals have strong influences on their behavior, such as teachers or peers. Behavior modifications have been used to increase or decrease certain behaviors. Some behaviors that parents have used behavior modification to increase includes teaching their child to walk, talk, toileting, and performing other household chores. Other behaviors that parents have used behavior modification to decrease could include tantrums, aggression, noncompliance, and oppositional or defiant behavior. Parents' adherence is crucial in order for an intervention to be successful, and sometimes parents require the assistance of professionals or professional tools. Some of the strategies for parenting and child management are involving behavior therapists, like clinical psychologists, that can help parents work with their children by treating the behavior problems directly. The Triple P positive parenting tool used for treatment or prevention of severe behavioral, emotional, and developmental problems and is regarded as an effective multi-level parenting program. There are also strategies within the community which are there to help support prevention of youth violence. This is a general overview of some of the progress that behavior modification techniques have made in education since 1960. First, there has been much more focus on disruptive behaviors, academic learning behaviors, and people with developmental delays or special needs. Disruptive or incompatible learning behaviors include out-of-seat behavior, tantrums, excessive socializing, and aggressive behavior. Behavior modifications began being used by physical education teachers in phys ed classrooms, and Fred S. Keller introduced the PSI, the Personal System of Instruction, which is used as a behavior modification approach to university-level teaching. This is a list of principles from the PSI, also known as the Keller Plan. These principles can be a guideline for teachers in order to improve classroom instruction. This slide provides a little more information about the PSI. Some limitations of the system are that it can be labor-intensive. This is especially true if the class size is large and is primarily due to extensive record keeping that is required. A solution that can help with the extensive nature of record keeping can be incorporating the use of technology. Employing the use of computers, videotapes, interactive video discs, and computer-delivered tutorials. These tools can help with online submissions of assignments or tests, allow for relatively quick feedback or grading of work submitted, and the ability of the student to be in a different location than the proctor or instructor. CAPSI is a computer-aided PSI. This was implemented at a university in Manitoba where it became very popular with both on-campus students and off-campus students. The most important feature is including the students who mastered a particular area of study to help with other students in that specific study area. In a study conducted by Svenningsson in 2009, CAPSI showed to enhance student learning and critical thinking. Due to its reported success, CAPSI has been adopted by several universities in teaching a variety of courses. Behavior modifications showed a great deal of success in the 1960s when it started being used with individuals who exhibited developmental delays. In the late 20th century, the term mental retardation was used to refer to individuals with intellectual impairments. In the 1990s, the term mental retardation was replaced by an alternative term called developmental disability. This term is one most often used today. When examining the definition of developmental disability by Congress through the Developmental Disabilities Bill of Rights Act, there are discrepancies in the terms developmental disability and mental retardation, which should be taken into account. The Congress definition of developmental disability is much broader than the term mental retardation. In 2006, the American Association on Mental Retardation, AAMR, changed its name to American Association on Intellectual and Developmental Disabilities, AAIDD. The group indicated the name change was based on being referred as intellectual disability over mental retardation was preferred. This history allows us to consider developmental disabilities as a broad topic with subtopics of autism and intellectual disabilities. Autism and intellectual disabilities are two atypical developments in which behavior professionals have had special interests in creating behavior modification interventions. This chart shows how the intellectual impairments were delineated through IQ levels and therefore were identified as levels of mental retardation. The levels include profound, which is an IQ under 20 to 25. Severe is an IQ between 20 to 25 to 35 to 40. Moderate, where the IQ is between 35 to 40 to 50 to 55. Or mild, which is an IQ between 50 to 55 to 70 to 75. The AAIDD defines the intellectual disability as a disability characterized by significant limitations both in intellectual functioning and in adaptive behavior as expressed in conceptual, social, and practical adaptive skills. This disability originates before age 18. AAIDD defines limited intellectual functioning as an IQ below 70 to 75, which happens to be 2.3% of the population. Before 1960, treatments and training were few and far between and limited to treating severe, profound disabilities. Between the 60s and 70s, three forces emerged. First were the normalization advocates, which helped to deinstitutionalize individuals with intellectual disabilities and assist them into living within the community. The second force, the civil rights activists and parents of individuals with developmental disabilities, worked towards establishing legal rights of individuals with intellectual disabilities and mandating that those individuals be entitled to attend community public schools and subsequently setting up specific programs to meet their needs. The third force were the behavior modifiers who developed technology that assisted in improving the behavior of those with severe or profound intellectual disabilities. Since 1970, there has been a wealth of contribution from countless interventions and studies that have effectively improved the lives of those with or affected by intellectual disabilities. Autism is also known as autistic disorder. The DSM is a diagnostic and statistical manual of mental disorders. Asperger's, PDD, and PDD-NOS are included as autism spectrum disorders. The DSM-4 recognizes PDD as an autistic disorder, however, ASD is not officially defined in the DSM. It is noted that 1 out of every 150 children are diagnosed with autism. These are some typical behaviors or characteristics of the autism disorder: impaired social behavior, impaired communication, abnormal play behaviors, repetitive or self-stimulatory behaviors, and similar behaviors of intellectual disabilities, which are like below average performance on self-care tasks. In the 1960s to 1970s, Ivar Lovaas developed EIBI, which is the Early Intensive Behavioral Intervention. It consisted of behavioral treatments for children with autism. EIBI focused on teaching social behaviors, eliminating self-stimulatory behaviors, and developing language skills. EIBI was found to have long-lasting improvements, and even after much criticism, was confirmed as cost and treatment effective and as a treatment of choice for children with ASD. These are some characteristics of schizophrenia listed from the National Institute of Mental Health. May be hearing voices others do not hear, may believe others are reading their minds, plotting to hurt them, or controlling their thoughts, may not make sense when speaking, may sit for long periods of time without moving or talking, and may seem fine until sharing thoughts with others. These characteristics, especially hearing voices and the belief in not controlling one's own mind, may cause fearfulness, withdrawal, or cause a person to become extremely agitated. In the 1960s through early 1970s, schizophrenia received a lot of attention, and by the late 1970s to 1980s, the interest in schizophrenia decreased substantially. It has been shown in studies that behavioral interventions can be highly effective for individuals suffering from schizophrenia. The two main treatment areas are social skills and cognitive behavioral techniques. Because social skills were determined to be a main factor of poor quality of life among schizophrenic individuals, it has been targeted as a behavior to be modified. Some interventions for building social skills includes positive social interactions, communication skills, assertiveness skills, job finding skills. Cognitive behavioral techniques are most often used in treating hallucinations or delusions. By the 1980s, behavior modification had entered more than 50% of clinical psychologists' practice, and behavior therapy became one of the top two orientations. Today, clinical psychologists are most likely to refer to their practice as cognitive behavioral therapy rather than entirely behavioral. Effectiveness of treating psychological problems with behavior-based treatments. Behavior interventions have proven to be superior in treating certain forms of psychological problems such as phobias, OCD, and depression. Many have looked at behavior therapy versus prescription drugs. Martin and Pear reference a book titled Taking America Off Drugs by Stephen Ray Flora. He states that most psychological problems are behaviorally based, not neurochemical or brain-based. Self-management of personal problems are something that many people experience. Some words that mean the same as self-management are self-control, self-adjustment, self-modification, and self-direction. When trying to modify one's own behavior, it requires the ability to learn specific skills and rearrange your environment in order to control your behavior. Some examples of self-management procedures include saving money, increasing physical activity, improving study behaviors, and controlling gambling. In the late 1960s, behavior modification was beginning to be used for medical issues such as sleep disorders, headaches, respiratory disorder, hypertension, seizure disorders, chronic pain, addictive disorders, and pain. The result of this practice is the emergence of behavioral medicine. Behavioral medicine is an interdisciplinary field which focuses on the correlation between behavior and illness. In behavioral medicine, close correspondence between healthcare physicians, nurses, psychologists, dietitians, sociologists, and various other specialists are necessary. Within behavioral medicine is a field called health psychology. Health psychology is concerned with psychological influences on illnesses and practices to help prevent health problems. Health psychologists have developed 5 areas where behavioral principles are applied. These 5 areas include direct treatment of medical problems, establishing treatment compliance, promotion of healthy living, management of caregivers, and stress management. Gerontology deals with loss of skills or ability due to old age or illness. Martin and Pear discuss the solution to gerontology is through behavior modification techniques. They suggest in order to do this, individuals need to build and learn new skills or routines and deal with anxiety or fear from inability to cope. More and more behavioral techniques are being used to help elderly and chronic care patients cope with their problems. Behavior modification expanded from the individual to the community by the 1970s. It was used for issues pertaining to decreasing littering, increasing recycling, community boards implementing problem-solving techniques, energy conservation and bus ridership, increase in attendance of self-help meetings by individuals who receive welfare benefits, and cooperative housing programs among college students. Glenwick created 5 trends to be used in community applications to involve individuals affected by intervention in all areas of the procedure, encourage self-management skills among individuals, incorporate accounts from participants regarding their feedback of the procedure, and focusing on antecedent versus consequent events, increase collaboration of professionals on an interdisciplinary level. Organizational behavior management, or OBM for short, was defined by Fredrickson and Lovett as the application of behavioral principles and methods to study and control of individual or group behavior within organizational settings. Some other terms to refer to OBM are performance management, industrial behavior modification, organizational behavior technology, and organizational behavior analysis. OBM is very data-oriented, and it also helps to emphasize staff activities, frequent feedback, and rewards. It is used by a widespread variety of both small, large, public, or private organizations. One of the earliest studies was one conducted by B.F. Skinner in 1973, which included the Emory Air Freight Company. They wanted to increase the placement of parcels into special freight containers. The supervisors implemented positive reinforcement through praise, which subsequently increased the performance of employees from 45% to 95%. These are some of the other uses of OBM. It can be used to increase productivity, decrease lateness or absenteeism, increase volume of sales, create new business, improve worker safety, reduce theft by employees, decrease shoplifting rates, and improve relations between management and employees. Blimke, Gowan, Patterson, and Wood defined applied sports psychology as the use of psychological knowledge to enhance athletic performance and the satisfaction of athletes and others associated with sports. These are some of the contributions made by behavior modifications to the field of sports psychology. It improved techniques for improving the skills of athletes, strategies for motivating practice and endurance training, changing the behavior of coaches, and sports psyching to prepare for competition. When dealing with individuals, you have to take into consideration their background. Culture, gender, ethnicity, and sexual orientation are all things that can influence treatment effectiveness. Below are a couple examples of how cultural differences can affect treatments. Overgeneralizing characteristics can lead to some potential problems. Professionals should keep in mind that no one group is exactly the same. For example, Asian Americans consist of 30 different cultural or ethnic groups. Each of these groups can differ in language, values, lifestyles, and adaptation patterns. In conclusion, behavior modification has come a long way and served a variety of individuals in a variety of settings in countless ways. Many studies have been made available through books, journals, and online databases which highlight the effectiveness of behavior modification on individuals' lives. Thank you for listening to my presentation.